Thank you very much, Todd. So we're having looked at the science of endocrine resistance. We're now going to look at some of the recent clinical trials in trying to improve endocrine therapy, and Steve Cheers going to address that topic and how it influences daily practice. Steve.
Thank you, Stephen, and thank you to the Education Committee for giving me this wonderful opportunity. So I've been tasked in the next 20 minutes to try to put together the results of clinical trials with now commercially available agents in our daily practice in hormone receptor positive metastatic breast cancer. These are my disclosures. So first of all, just to highlight a couple of guidelines and consensus statements. This is a nice consensus guideline put together by Fatima Cardozo and colleagues in regards to various aspects of the management of advanced breast cancer. In their statement regarding endocrine therapy, what they state is that the preferred option for hormone receptor positive disease, even in the presence of visceral disease, unless there's concern of proof or concern of endocrine resistance, is for hormonal therapy, unless there's also a need for a fast response. The NCCN guidelines have also stated something very similarly, and in regards to practical recommendations, their statement is that consider up to 3 consecutive lines of hormonal therapy, regardless of clinical benefit or not, prior to moving on to chemotherapy, unless, of course, there's symptomatic visceral disease. I think the challenge that we face in our practice, though, is that there's numerous types of strategies or approaches, and they're just outlined down here, whether you start with tamoxifen and move to an aromatase inhibitor, or which type of aromatase inhibitor, and likewise also the utilization of the estrogen receptor downregulators. And probably what drives most of the clinical use of the strategy is what the patient may or may not have been exposed to in the earlier stage setting. So I think it's clear, though, that you want to use your best hormonal agent earlier. And I put best in quotations because that could be efficacy, and we recognize that the earlier you use an agent, probably the longer the benefit or the greater duration of benefit you'll get out of it. But best could also be the toxicity profile of the agent relative to where the patient's stage of disease and symptoms is, or best could be what you can access or what the cost is to the patient, or probably best of all, is really to put them on a clinical trial if there's one appropriate. So rather than kind of bore you with a whirlwind tour of the clinical trials that probably very many of you are well aware of, I thought it was focus the rest of my time in regards to trying to answer 4 questions that I think are relevant today. And that is, does the sequence of hormonal agents that we use actually matter? And secondly, as you'll see, the trials have a mixture of both de novo metastatic breast cancer and as well as patients that have previously been exposed in an earlier stage setting. And is there differences in both their biology and thus their clinical outcomes? Very importantly now, the issue of combination hormonal therapy, is it better than appropriate sequential use? And lastly, just a couple of points in regards to, can we really identify, based on characteristics that we have, clinical characteristics, perhaps within the tumor, to select the appropriate hormonal agent at that point in time you're seeing the patient. So sequence. My thoughts are, it really depends. Does sequence matter? It depends on the endpoint. Are you looking, and you and the patient are looking at prolonging progression-free survival without really benefiting overall survival, or vice versa? Is overall survival the most important endpoint? When we look at the trials, consider where there was appropriate crossover. Consider the heterogeneity of the patient populations, and then I will make a point in regards to whether the optimal dose was used in the studies. And I guess lastly, when we look at all the studies that have been published so far, how relevant are they today to the women that you're seeing having a relapse post an adjuvant AI? Because keep in mind, most of the studies, they were the minority of the patients. So in regards to sequence and overall survival, perhaps the best study to look at this in the first-line setting was the P025 study. Over 900 patients enrolled in a double-blind, and more importantly, crossed over at time of progression where they were still blinded to letrozole, tamoxifen, and as I mentioned, the crossover. This study, as you well know, it's been over a decade now that it's been published, showed that letrozole was superior to tamoxifen in prolonging progression-free survival. I'll just highlight the number you kind of remember is 10 months versus about 6 months. But when a study was appropriately designed and crossed over, and about half the patients on this study crossed over in a blinded manner, though there may be early differences in survival, when we look at the overall curve, so use the Lagrange test, there's no difference in overall survival, whether you use letrozole first or tamoxifen, vice versa. Yes, there's difference in PFS, but perhaps not in OS. So then you might say, well, we know that in first-line setting studies, what the treatment they receive post-progression, and thus the crossover, has more of an impact on overall survival. So let's look at a couple studies where the study design was really in second and third line, and the impact of post-progression treatments perhaps more limited. So in the EFFECT study, where we randomized close to 700 women who've had all received prior non-steroidal aromatase inhibitors, so these were predominantly in the second or third line setting, to what we called at that time a loading dose of fulvestrant versus exemestane in a double-blind, dummy manner, we showed no difference in PFS here, about 3 months. And likewise, in a study that was led by Dr. Johnson, where they had a very similar design of exemestane versus fulvestrant with an anastrozole placebo, again, all patients were having had prior exposure, but not only exposure, but, quote, sensitivity to a non-steroidal aromatase inhibitor, they showed virtually an identical result. No difference in PFS, and again, the exemestane arm was about 3.5 months. Very recently, led by Stephen and his group, we did a meta-analysis of both EFFECT and SOPHIA. As I outlined, they were very similar patient populations for the most part. And in regards to overall survival here, there is absolutely no difference in terms of the sequence of using a steroidal aromatase inhibitor versus fulvestrant at the loading dose. And in the median overall survival, second to third line setting, the number I kind of remember is about 2 years. So back to the question about the optimal dose, and fulvestrant, those of you may well be aware of, has had a relatively long gestation in coming up to what might be the optimal dose. So in a study led by Angelo DeLeo, really studying the previous dose of 250 versus the 500, which is different than the loading dose, they in fact had previously shown that the 500 dose, day 1, 14, 28, and every 28 days thereafter, did improve PFS, hazard ratio 0.8, though the absolute difference was modest at a month. But what Angela showed at this past year San Antonio was that there appears to be, or there's a trend to an overall survival benefit. What happened with the study was they spent their entire p-value on the first analysis, and thus it was quoted as a nominal study. But what's unique about this study is you don't need to worry about the crossover because the drug is identical. It's just basically looking at the dose. So I think, it's easy to look in retrospect, but if we were to design the EFFECT and the SOPHIA study today, probably Stephen and I would have both recommended using the 500 milligram dose. So what if we had a bit of a glimpse in terms of using that dose compared to another standard hormonal agent we use, anastrozole? So this study led by John Robertson, it's been presented on a couple of occasions now, is relatively small. It's a randomized phase 2, comparing, as I mentioned, perhaps the more optimal dose of fulvestrant to anastrozole. What's unique about this study that I want to highlight, though, is about 3/4 of patients had no prior endocrine therapy. So again, I wanted to highlight that as one of the points is these may be different patient populations. When the study was updated by John, he showed that, in fact, using the more optimal dose of fulvestrant had a better time to regression, hazard ratio 0.66. But as impressively, look at the absolute time to progression. Virtually, it's 2 years versus about 1 year of fulvestrant versus anastrozole. So this is a randomized phase 2, and we now eagerly await the results of the phase 3 trial called Falcon. That trial is up and running. The planned sample size is about 450, and apparently they're about a quarter of the way accrued. So let's move on to the question about combination. Does combination matter? And again, I think it depends on what the endpoint trying to be achieved here, PFS versus OS. And I'll break down that talk in terms of combination of hormonal versus pathway inhibitors, again, the issue of crossover. But there's more unique issues when we talk about blocking pathways in combination with hormones. Which pathway? Where in the pathway? Upstream, downstream, both up and downstream, or multiple pathways? You can imagine the complexity of this. And this whole issue about compensatory or redundant pathway activation is really an important one that I think Stephen will talk on more in his talk. So a couple studies of combination of hormonal agents. The study led by Jonas Berg called the FACT study was in the first line setting, used a loading dose of fulvestrant with anastrozole versus anastrozole alone. And here I wanted to highlight about only 30% of patients had no prior endocrine therapy. This study showed no difference in time to progression, and very similarly to what I showed you with the upfront letrozole versus tamoxifen in the P025 study, the median time to progression is about 10 months. And as you would expect, there's no difference in overall survival, and again here the median overall survival first-line clinical trial is about 3 years. Now, that seemed to kind of settle the issue perhaps, and in fact in the NCIC clinical trials group we had designed an adjuvant trial for the combination, and that was sunk with the FACT trial. Then came the S0226 study, a SWOG-led trial, was virtually identical in design, first-line therapy, similar, exactly identical treatment regimens of the randomization. The difference here, however, is that on this study, about 60% of patients had no prior hormonal therapy, meaning no tamoxifen in the adjuvant setting, so double that what was seen on FACT. And what they showed, in fact, that there was a benefit for PFS for the combination of fulvestrant at the loading dose with anastrozole, clinically marginally or modest, you would say, a hazard ratio of 0.8. But it did translate to an overall survival. And here again, the hazard ratio of 0.8 and an absolute difference roughly about 6 months. Now, to state the issue about crossover, about 40% of patients on this trial that were randomized to anastrozole alone ultimately received fulvestrant at a later point in time. But the point why I wanted to also highlight the difference of de novo or no prior hormonal therapy is when they looked in this subgroup of patients, and they did stratify for that in their design of prior tamoxifen versus not, in the patients that had no prior hormonal therapy, this is where you saw a slightly greater magnitude of benefit, hazard ratio 0.74, and here the combination arm, you're getting almost up to 4 years of your median overall survival benefit. So the last bit of the talk will focus on blocking combination of hormonal agent and pathways. And I want to focus first in terms of the upstream blockade. So perhaps the best study, and again led by our chair here, Dr. Stephen Johnson, had to do with the letrozole in combination with placebo or letrozole in combination with lapatinib. As you're aware, lapatinib is both a HER2, but it's also an EGFR inhibitor. This trial was unique that it did not only focus in terms of its enrollment on HER2 positive patients, but included those that were HER2 normal or what you could call negative, and they also stratified for prior response or sensitivity to tamoxifen therapy. As one would expect, and they did demonstrate in the study, in the HER2 positive population, there was a significant and clinically significant benefit in adding lapatinib to the letrozole, hazard about a 30% improvement, and in the median goes from about 3 to 8.2. In Stephen's presentation and what was in the publication, there is a trend for an overall survival benefit, but it's not yet there. The number of events were not mature, and we eagerly await the results of this updated overall survival benefit. What we will need to pay attention to is the crossover, how many patients on the placebo arm ultimately got an anti-HER2 at a later line of therapy. Now, the other thing, though, that you can gain some insights from this trial, and I know that Stephen purposely planned this trial for this, was that in the group of patients that had, for the most part, no hormonal therapy, so no opportunity to develop, quote, acquired resistance, there really was no benefit in the subgroup to add lapatinib. However, in the group of patients that you could argue had a relatively early acquired resistance, so the median duration on adjuvant tamoxifen was about 3 years, there was a signal there to suggest perhaps this pathway may be involved in relatively early acquired resistance. And more on that in a moment. Now, the TANDEM study also addressed an anti-HER2 here with trastuzumab in combination with anastrozole or anastrozole alone. It did show a very similar magnitude of benefit in PFS, but what they have published is that there is no difference in overall survival. And this is perhaps and probably because 70% of patients at a later point in time received trastuzumab during the course of therapy. Now, just this one single slide in terms of EGFR blockade in combination with hormonal therapy. There have been 2 randomized phase 2 trials, both of them well performed with placebo-controlled, and both of them suggesting, one statistically, the other not, that there may be a benefit to adding EGFR inhibitor in combination with hormonal therapy. So I will leave the MINT discussion to Dr. Johnson, as he's the PI of the study. This was presented in a poster discussion yesterday, and I think this adds further insights in terms of this field. AZD8931, as he'll describe to you, is a HER1, HER2, HER3 inhibitor. What was unique about this population, and perhaps you could reflect back on the lapatinib letrozole cohort with no prior tamoxifen I showed you, was that these were all endocrine therapy naive. The last few minutes is then I want to focus in on terms of this downstream pathway blockade, predominantly the PI3-AKT pathway. Dr. Mueller nicely highlighted with long-term estrogen deprivation, there's activation of that pathway. And clearly the most important and clinically relevant study is the BOLERO-2 study, published in the New England Journal. It's a 724-patient, 2-to-1 randomization of exemestane. Now, and it's important here that everybody had previous exposure to a non-steroidal aromatase inhibitor and either received everolimus at 10 milligrams a day or placebo. Just to highlight, as I mentioned, everybody had prior non-steroidal, and 85% were coded as sensitive to the non-steroidal, to the prior hormonal therapy. Though the majority of the patients, this was second and third line therapy, 20% of the patients actually got onto the study as their first line in the metastatic setting, meaning their last treatment being a non-steroidal was in the adjuvant setting. We all know the results of the study. It's both statistically and clinically impactful. Hazard ratio 0.44 and a difference from 3.2 in the exemestane only arm, which I will highlight is virtually identical to what we saw in SOPHIA in effect, to 7.4 median time to progression with the addition of everolimus. I think those of us that are using this in our practice recognize the challenge comes in managing the toxicities, and even though the proportion of grade 4 toxicities is really very minimal, the grade 1 to 3 are more in terms of stomatitis, diarrhea, anorexia, and then rare things like non-infectious pneumonitis. Now, further evidence to both this agent and blocking this pathway has been the TAMARAD study. This is very similar in that it only accrued patients with prior exposure to non-steroidal aromatase inhibitors. But here the combination was not with exemestane, but was with tamoxifen. And very similarly to what we saw in BOLERO-2, the hazard ratio is 0.4, and you get a virtually doubling of the time to progression from 4.5 to about 8.5 months. Now, that is not the only mTOR inhibitor trial. There's one that's been previously published by Antonio Wolf and JCO earlier this year of temsirolimus, but this was in first-line setting, and here about 2/3 almost of patients had no prior hormonal therapy. This study was negative. There was no difference in PFS and no difference in OS. And trying to then correlate why BOLERO and TAMARAD had significant improvements in PFS and Horizon didn't, keeping in mind BOLERO-2 and TAMARAD, all patients had prior non-steroidal aromatase inhibitor therapy. It goes back to the preclinical data that Dr. Miller has been involved in that mTOR tends to be activated by estrogen deprivation. So this is perhaps a pathway that is activated in the development of acquired resistance. To end, I just want to say, in terms of the last point of selection of optimal agents, we raise a question, are there patient characteristics that help us select? Are there tumor characteristics that we receive on standard pathological assessments that might help us select? Or just simply a definition of hormonal sensitive versus hormonally resistant, is that predictive? And then lastly, the big question is, will molecular profiling, whether it be the genome, the transcriptome, or the protein, provide predictive capacity? So if we just look at the effect in SOPHIA that I described earlier, and we just looked at these clinical characteristics, you can, just scanning the forest plots, you can see there's really no difference in prediction of one agent versus another in those characteristics. Likewise, in BOLERO, combining it with everolimus, if you kind of scan down again the forest plot, everything favors a combination of everolimus and exemestane, and one cannot necessarily distinguish one versus the other. The one that I just want to highlight, this hormonal sensitivity, again, was 80% in the BOLERO-2. That is the group of patients that in TAMARAD tended to have the greatest benefit, and likewise on BOLERO-2 favored more to the left of a greater hazard ratio. So just two more studies to highlight whether we're moving forward to in terms of molecular profiling. This is a work led by Matt Ellis at WashU, where they did whole genome analysis on a number of samples from patients treated with preoperative hormonal therapy. And I'm not going to go into the details of the results of the study, but I wanted just to highlight is that what they found was that pathway signatures, related connections between mutational status and clinical outcomes. In work that was led by Sam Aparicio at the BC Cancer Agency together with Carlos Caldas at Cambridge, they looked at 2,000 breast cancer samples. These were all early stage disease. And they subtyped them not just into the typical subtypes we think of luminal A, luminal B, HER2 enriched, and basal, but applying both the transcriptome and array CGH, they actually described 10 subtypes. And what I wanted to highlight was that in the ER positive intrinsic subtype, or if you want to call luminal A, luminal B, that is where the greatest heterogeneity was of the difference in prevalence of these subtypes. And whether these subtypes will then inform us better in terms of prediction, that is yet to be answered. So to conclude, I do not believe that at this present in time it appears that the sequence of hormonal therapy alters overall survival. Clearly it alters progression-free survival in the upfront setting, but not overall survival. I believe the combination of fulvestrant and AI warrants further evaluation, particularly in earlier stage, and that is being looked at in a neoadjuvant design called ALTERNATE. The combination of anti-HER2 and AI provides modest PFS improvement, but perhaps not at OS. And in my practice, I tend to reserve my anti-HER2 in the first-line setting with chemotherapy, and then utilize my hormonal agent as an add-on during the maintenance phase when they're on their anti-HER2 alone. One could consider patient populations, perhaps older, frail, that might never receive chemotherapy. That would be a reasonable patient population to consider. The combination of everolimus and exemestane, and to some degree tamoxifen, it's a smaller trial, I think is both an important in terms of understanding the biology of acquired resistance, but clinically relevant in advance. What we need to do better is predict who achieves the benefit, predict who might develop the toxicities, and manage the toxicities. And as a message I think we're all going through, learning to give this combination, we need to see these patients in a more frequent and earlier manage to manage their toxicities earlier on. Lastly, the molecular interrogation of tumors, I think, clearly provides a more refined prognostic profile. But the question, both the money and the hope is, will this become more predictive? And with that, I want to thank you for your attention.